We've got around 15 minutes or so for questions. So whilst you're just thinking what to ask, we've had a number of questions that have come in already. Kelvin, we've got two for you to start off with, so if you want to come up. The first one is the cost of the catheter for the Ion is £2,000 per patient, and your tariff is only £1,600. How do you convince managers to invest money in something which is losing money?
So actually the procedure cost is not that far off the navigation bronchoscopy catheter system. I think it's a little bit more, but both of them are loss-making. Well, both of them are loss-making, I say, but I use a trick, which is I code my procedure as a CT-guided biopsy, not a bronchoscopy, and that gets me a higher income. The other thing is I go to my hospital and I say to them two things. One is I made a profit last year. I made a substantial profit in my department, and that's by doing navigation bronchoscopy, that losing money. So clearly, it's not losing that much money because the volume replaced by it, I'm still in profit. Secondly, I show them the number of cases I have ended up resecting because a lung resection is profitable. So I'm bringing all these cases, which would have been for follow-up imaging, and I'm operating on them now, and our volume goes up. So the hospital have to, well, the two things is, one, the hospital have to accept that actually there's downstream income from this. But also, I think as a society and as a group, we have to negotiate a tariff for this advanced technology.
Yeah, okay, no, I agree. So it's almost like a loss leader. On-site cytology improves yield. Please comment on new technology that might be able to avoid tying pathologists to the operating room.
So I don't have the luxury of rapid on-site pathology because we're a cardiothoracic and cancer hospital, so pathology lives in the acute hospital a mile away, and they will never come and spend a whole day with me. But we have spent some money and bought them a microscope and camera to do this digital pathology, and you probably just teach the nurses how to dunk the slides if you need to, but we've never got that far because the pathologists have been very short-staffed to come and train us. But digital pathology has the potential to make sure that you don't need a pathologist full-time in your theatre all the time. Tom has experience with Rose, and I think it's very positive, isn't it? Yeah.
Yeah, definitely. If you can get the pathologist in the room, we definitely reducing the operating time as well as increasing the yield, which is
yeah.
Well, why not just beam on the image like everybody else?
Yeah, so that's the digital pathology, the connection.
That doesn't need to be digital. You can use it on a cell phone.
Yeah, I guess. We just need the camera set up so that we can take the picture of the slide. Yeah.
Okay. Surf, you might want to take this. As we know, AI is coming to assist in robotics more. How is AI making an impact at present, and what have been the results so far?
Yeah, so I love questions about AI. It sounds so sexy. AI, let's invest in it. I have a lot of NVIDIA, so that was a good job, right? No one even knows what the hell it means. So it's usually nothing more than taking data sets and looking at statistical analysis of it and looking at trends, which is what, by the way, you do as a surgeon. Great surgeons immediately put a camera in the chest and they can see the entire operation because you recognize patterns, and that's what AI does. Having said that, there are a few companies, maybe 1% of AI is actually AI. The other 99% is pattern recognition. So I think AI is going to do great for pathology, radiology. It's going to reduce the time of MRs. Right now, we used to have to put people in machines for 20 minutes to do MRs of their knee. Now we can do it in 7 minutes. That's really AI, getting better images. And maybe in education. And so in thoracic surgery, there really is no real AI. There's very little, but maybe there will be in education. Having said that, I would say, again, we've talked a lot about cost, but you hear what he said, and this is the problem with papers on cost. If you just code something differently, now all of a sudden you're getting more money. Is that legal? That's a different question. But is it ethical? Yes, because you're making an argument. I always hear about downstreaming as a COO. Everyone talked about downstreaming. That's such baloney. We don't even know what the hell that means. We're one pocket. So as I said, NYU is a $9.2 billion organization. We made $800 million last year. And when someone knocks on my door and says, I want more money because my cancer center made $400 million, before he leaves the room, I can make him lose 200 million. Just by saying, okay, every lung cancer operation doesn't go in the cancer center, now it goes in the Department of Cardiothoracic Surgery. So with a sweep of a pen, you can take people's profits and move them. So you should look at your healthcare system as one pocket, one giant pocket. We have 38 clinical programs at NYU and only 4 make money. Only 4. The other 34 lose money. And so those 4 programs are paying for everybody else. So we can move things around. Next question.
Yeah, so this is another one for you, and I feel this person's pain. I agree with them, so here we go. This person loves your techniques and entirely uses your lymphadenectomy technique, but he does have air leak, which interestingly, I also have air leak.
So do I.
Yeah.
All the time, which is frustrating.
I have no idea how to be good enough to not cause air leak. Any tips on preventing air leak?
So let's
during
make it
surgery?
clear. I talk about how great we are preventing air leaks, and last week everybody had one. Not a single person got their tube out. They all went home on post-operative day 1 with a chest tube. So the key to really air leaks is how you handle the lung. So the majority of air leaks, I think, are remote to where you think they are. You all think they're from the staple line. I saw the video where putting adjuncts on lymph nodes or Pro-Gel on the staple line. But the surgeons that I used to train, they would retract the right lower lobe. Say they're doing a right upper lobe, they retract the right lower lobe, they take out 987, and your air leak is from that retraction. So everyone uses a sponge. I hate putting sponges in the chest because it adds time, and then you have to take them out, which adds time. It's nice to have a medical student pick up a sponge. They get them on the robots. The only good thing about putting a sponge in the chest, the medical student can sit on the console and take a sponge off. That's the only value of it. You should learn how to retract the lung better, which we call passive retraction. So we can talk, these are very specific, which I love videos. Everything's in the video. I saw a lot of videos here. Why would you have unipolar? Never use unipolar. I'm sorry, I disagree with all of you. You should use only bipolar in both hands. Why would you ever have a stick? For Christ's sakes, why would you have a stick and a cautery in one hand? Doesn't make sense when you have something that can both burn and grab. So both hands should be something that can open and close, and both hands should be bipolar. Much safer to train. You don't get the spark and gap effects you do with unipolar. So everything's on the video, in my opinion. But I think all these things are trainable. But air leaks, we still have them. I still send 9% of my people home with a chest tube on post-operative day 1, and then they text me every day. I've gotten 4 texts today from people who are home with a picture of the digital air leak, and when that air leak is less than 20, we take them out in the ER on Saturdays and Sundays, and my office Monday through Friday. That's the advantage to a digital system. The chest tube comes out sooner for the patient. I love when the hospital says, show me the money. Well, show you the money. No, they're home, but it's better for the patient. So again, it's not all about money. It's about a better experience for patients, a better experience for the doctors. It's better for the doctors not to go round and listen to a patient complaining about their pain and their chest tube. Send them the hell home, and then they just text you, and you don't have to listen to it. You can read it when you want to read it. That's value.
Couldn't agree more.
How many of your digital systems end up on eBay?
Yeah, so
That's true.
it's a great question. So we actually put RFT tags because we had about a 3% loss of air leaks, of air leak systems. I had a patient try to sell one on a street who still had it in his chest. It's a true story. I operate on people with no money. I'm proud of that. This guy went out of the hospital on post-operative day 1. On post-operative day 3, he was trying to sell his digital system hooked up to a chest tube on a street of 48th and 3rd Street in New York City. And fortunately, because of our RF tag, we saw that he had left the home he was supposed to be in, and that didn't happen, thank God. But yeah, you got to be careful.
Hi. Thank you so much. The really interesting and informative session. I loved it. But I'm really concerned about something that came across to me from the first 3 speakers, and this is that the evidence is not important.
Great.
Right, now let me just talk about this, right? And listen to me, please. The evidence is really important, and you guys, especially the 3 people who stood up there, have to stop saying it's not important. What you need to do, please, is to tease out the bits of it that provide the evidence. And I'm not saying we have to do randomized controlled trials. We all know there's an industry behind randomized controlled trials, and they're a very poor substitute for a complete data set. But what we need to do is say, this is the evidence that it's more comfortable for a surgeon. This is the evidence that makes it better for the team. This is the evidence that makes it better for the patient. And then you will make it so much easier for us to get the support, funding, and buy-in, so we don't have to follow the long learning curve and long implementation curve that there was for VATS. The three people who spoke, you're all in fantastic institutions, you've got it, you're there. But the rest of us, we're a long way behind. So please, can we change that dialogue?
So this is a great comment, and I'm going to agree with you 100% and then disagree. So for these talks, pain, length of stay, the data's terrible. I put up all the data, and I said you can go through it all, and I went through it all at length. But if I'm going to come to the podium and I'm going to shoot the data down, I could shoot 1 million holes in it, and I showed you how. Heck, you talk about length of stay. When we send everybody home in a day, whether you do it robotic or VATS, okay? So it's not there. It's how it's designed. Or pain. I told you, someone uses a 30-degree camera and someone uses a 0, the pain's completely different. It wasn't in the study. So that's the problem. You're right. I've designed a whole bunch of prospective randomized controlled trials, and even I have shot holes in my own data. So when you're looking at immunotherapy or chemotherapy, prospective randomized trials are great, and we need them. When you're talking about pain and length of stay for robots for VATS, the data isn't important. I'm sorry. I've read every report. There's too many holes in it. So we're not saying prospective randomized trial data is not important. We're saying for these specific variables, for these talks, the data has too many holes in it. So of course data is important. We all are evidence-based, and we do evidence-based data in everything we do. But for comparing VATS to robot, the data's not there based on how it's currently done.
Yeah,
That's the point.
Neil.
Thank you. Aman, that was great, actually. Kelvin, this is directed to you, actually. In Leeds, we've done well over 800 cases of NAB bronch using a first-generation machine, the Super D. Our biggest challenge is that we've got a 40% false negative. Now, I agree with Aman that the evidence, or the existing evidence, is important, and somehow when you get to diagnostic bronchoscopies, we can talk all we want about your experience. And you know that for ablation, in all these years, I haven't been able to get into or we haven't been able to get into the hybrid theater, so we send you all the cases for ablation. I think it's important we not just look at the existing evidence. And fast-moving technology like this, we also get ahead and say, look, we need to get rid of these false negatives. We need to come up with a financial structure for the whole of NHS, because this is where image-guided surgery is going, image-guided thoracic surgery. It's not just a robotic bronchoscopy for diagnosis or the surgical robot. It's the whole pathway, the whole ecosystem. And I think that's lacking. And I agree with Aman. Pectus is a far less, we heard about pectus this morning, and pectus is a far less common disease than lung cancer. So.
Yes, I completely agree with you. And the data we have for so for the iron, for example, there's only one other prospective study, the PRECISE study, which is why we're doing these procedures currently on the prospective study, exactly as you said, because we want prospective, well-designed study trial data, and it's multi-centered. So that also helps. In fact, there's a separate similar study being run in the Netherlands at the moment. And I completely agree with you. We need to go. It's the same for robotic lung resection. We need to go to the funders and get a tariff properly established for these procedures, because more than half the people in here are doing robotic surgery, but it's not robotics resection, but it's not coded or funded appropriately. And technology moves a lot quicker than that. But there's enough evidence to support it. So I think it's probably something that we have to do with the society.
Okay, thanks, Kelvin. I'm just going to let Tom answer Aman's question. Maybe at the same time, you might want to comment on the Raval trial as well.
Yeah, just to provide a UK perspective as well. You're right. Perhaps we came across as a little bit facetious, but if so, it's a response to, I think, really a global trend to hold robotic surgery up to an evidence bar that is unrealistic and to which other new surgical technologies are not subjected to. So there's been a voice within the surgical community saying we shouldn't transition to robotics until we've got high quality, high volume level 1 evidence because it's too expensive and we shouldn't do it until we've got to that point. Robotics is somewhat expensive, although I think not as expensive as people think. If somebody wants to bring in a new advanced energy device, a new version of Harmonic into their department, no one says, show me the global 10,000 patient RCTs showing that this device, this new technology will prevent death. It's allowed in on much softer credentials. And I think there is some frustration amongst the robotic early adopter community that the evidence bar that is required of robotic surgery to justify the transition is too high and is not a requirement that other new adjunctive surgical technologies are subjective to. So yes, of course, we need to continue to pursue evidence, although the evidence base already is pretty good in a patchwork sort of way. But I think we have to be careful not to subject the transition to robotic surgery to a higher and unachievable evidential bar than other new adjunctive surgical technologies, because it's just another tool like a Harmonic, like a 3D VAT stack, and we have to not ask unreasonable evidential demands.
Yeah, may I just come back to that? So
Very quickly, because we've run out of
I'll be
time.
really quick. I want to be very, very clear, right? The people who are the early adopters, the pioneers, the leaders of robotic surgery, we have great respect for, and I want you please to get rid of that persecution complex, because you are not being victimized, and nobody, absolutely nobody, wants to set an unrealistic bar. I just want to see a consensus statement which says it's better for the surgeon, it's better for the team, and these are the advantages for the patient. I don't care about length of stay, because as Bob said, you know, we're already doing 1 day. Yeah. I don't care about how much seepage of liquid there is, because it's not important. And we know how to manage chest drains, and we're getting better at it. So no, you should not feel that we need to have a randomized controlled trial of 10,000 patients, I think you mentioned. We don't need that.
Yeah.
I just need like a consensus statement, and then we can take that through to the NHS. And that's the single advantage that NHS England has, that if we get agreement and we say this is better, we can actually do it. It's when we're fragmented we can't. So I was a bit facetious about the persecution complex, but
This is a messiah complex, not a persecution complex.
So let's do it.
So I think that's a nice way to wrap up the session. Before we finish and congratulate all our speakers, I've just got a few announcements. Firstly, can you rate all the talks via the app? Secondly, we now have 2 lunchbox sessions starting at 12:30, so you've got 10 minutes to grab a lunchbox, and then there'll be a robotic session in here, and there's an AtriCure session in another room. And finally, please put your hands together and congratulate all the speakers for what's been a great session.